When I saw the list of diseases to choose from, I did ponder a bit on which disease was more prevalent to the pathogenesis or more prevalent to what we were studying at this point. Then I came across Impetigo. And to some, they might not know what that is if they don't have children. I can tell you that I had no idea what Impetigo was until 2021, which is about 4 years ago. We raised 5 children, and my last child had some scab on her nose, and I had no idea. And a friend of mine worked at a school, and she's as a nurse, and she's like, "Oh, that's impetigo. Your kids get it all the time. No big deal." And that's pretty much, where it was left at. And later on, I'm going to explain to you a little more of what can actually happen if you don't understand what it is, and you do not get treatment and the things of that sort, because there's so many different types of bacterias that now they're showing, there's MRSA involved. There's just a whole bunch, but we're going to get into it. So impetigo, the school sores, pathogenesis explained. So when I say school sores, that's what it's been known for years. Like I said, I never had a chance to deal with that with my other children. Why, I'm really not sure. They went to public school and, you know, um, in very close settings and things like that, but somehow or another they just never got it, or maybe their immune systems were a lot better. There's so many different risk factors that go into it. But we're just going to go on here I want to go to the next slide and give you a little rundown what we're going to go over. Definition, we're going to give you different types, go over the etiology, the pathogenic mechanisms, pathogenesis of the disease, complications that can occur, and epidemiology of impetigo and who's at risk. So impetigo, it's a rapidly spreading, highly infectious gram-positive bacterial infection that affects the outer layers of the skin. And when I say the outer layers of the skin, I mean the epidermis. That we have so many layers of the epidermis, and the dead skin that sloughs off and all these things. But most of your bacteria you're going to see in impetigo, they're going to stay on the surface. This is why they call it a it's called a surface skin infection for a reason. There are two forms of impetigo. There's bullous and non-bullous. Bullous and impetigo, it is more rare. You really only see it in infants, which actually accounts for like 90% of the cases. And non-bullous impetigo, which is your most common form. That's what most people have seen. And for some reason or other, men also are a higher chance than women to get it. But it's, mostly you're going to see this in children. Like I said a while ago, impetigo is the most common skin infection. It's found in young children aged 2 to 5. And the non-bullous impetigo, it counts for like 70% of all occurrences. And, in bullous, I think, represents around 10%. There has been an increase in antibiotic resistant strains of the bacteria. Which, we all know MRSA, and there's several other different antibiotic resistant bacterias. But, and they're counting these in places where you have a closer setting, whether it be like in prison or daycares or kindergarten, because we all know when kids are in kindergarten, they're all sitting amongst each other and all want to play and they have no boundaries. Because we've mostly seen this, in hospitals. Somebody's got a long hospital stay and they've, had, some abrasions or something like that, or some lesions or something. And while they're there, skin to skin contact, whatever it may be, that's where you normally see outbreaks. Non-bullous impetigo is caused by either Staphylococcus aureus or Streptococcus pyogenes, and is identified. It has honey-colored crust on the face, and you will always see it. It literally looks like if you swabbed it, it was honey that you would just take out of a beehive. There's this really, really defining color to it. And the type, they can occur after skin bites, eczema, herpetic lesions. And you have bullous impetigo, which is solely caused by the Streptococcus aureus. It develops large, soft blisters and is more likely to arise in areas where the skin rubs against itself. When non-bullous impetigo is caused by group A Streptococcus, which they call GAS, G-A-S, it's a rare form of impetigo can be formed called ecthyma. This infection penetrates deep into the epidermis and all the way to the dermis, actually, and becomes systemic without treatment. So when I say systemic, people start getting infections and start spreading to other parts of their body. Their immune system kind of like freaks out, and so they can fever and they can have diarrhea, some gastrointestinal issues. because it's our body's way of saying, hey, like something's not right. And we'll get on later on, there's some things that could happen there. So the three impetygos are dependent on the type of bacteria, transmission, immunity of host, and hygiene. The pathogenesis is something that we're studying right now. And so basically, we're through these slides, I hope that I can, describe how this disease develops, it progresses, and either persists or it's resolved. In most cases of impetigo, they are resolved. Those severe cases are only very small percentages, but anybody can be that percentage. So we have two different mechanisms here. We have primary and secondary. So in your secondary mechanism of impetigo, it's your direct contact. So you have healthy, intact skin, no kind of sores, no kind of open lesions or anything like that on your skin. And that's going to be your primary, and you can be bullous or it could be non-bullous impetigo, and and that's just an infection of the epidermis, which is your outer layer of your skin. Now, secondary types are, it's going to be, it's a bacterial infection of a disrupted skin. So, if you've, like I said, went out in the garden, you've gotten bit by, I don't know, mosquitoes or some type of bugs, and you have like some little open wounds, or, you may have eczema, and you have some open, you scratch your eczema sores and they're open, and then you come in contact with it somehow or another with the bacteria, and that's how, the secondary, and this is causes and breaks in the continuity of skin, which I will define the continuity. It's just like the skin is it's continuous. So when you cause that break, then the outside of our skin, which is our largest organ, and it protects us from all the outside and things in the outside world, and so that membrane has been penetrated, and so it's not able to protect you like it should. And like I said, it shows on here is trauma, burns, insect bites, surgeries, scabies, chickenpox, all, so let's go to the next slide. Sorry about that. So pathogenesis of impetigo. I'm going to do the first form here. It's non-bullous. And I talked about a while ago, it's, the types of bacteria it comes from. The one thing about it is, so you're going to follow this pattern, and through this pattern, it's developing, and it's thriving, and it's trying to do what it can do because it's a bacteria, and that's what it does. And it's trying to penetrate, and it's finding a host cell and just, go with it. Local production of exfoliative toxins. So the bacteria itself, depending on which one, is going to produce certain types of toxins that will cause like a blistering of the skin, and that's where they almost look kind of like chickenpox sores, but they form a blister, and like I said, they have different colors, and the colors is what really sets them apart from the others. And you'll learn, like as far as differential diagnosis, with impetigo, that's one thing that if the child's never had it before, you want to make sure that that's what it is, because it can resemble other things, but with the non-bullous, that yellow honey colored crust, it's really nothing else I've ever seen that looks like that. But so once that toxin has been produced locally, then it's going to start as a maculopapular lesion, which are little flat, discolored raised bumps, usually found on the face or extremities. That's normally where you'll find the non-bullous impetigo. And it's going to transition into thin-walled vesicles that rapidly rupture. And so once they rupture, that's when that crust is going to be formed. It's very superficial. It's on the outside, the erosion is, and it's got that honey-colored crust. And the infection usually lasts 2 to 3 weeks, left untreated. So like if your child's had it before, or maybe you're taking care of someone who's elderly and they've had it before, or what it is, the sooner you get them treatment, whether it's just a topical, antibiotic or something like that, the faster it's going to go away. Because, some of the forms can be very painful for some. And with this form, it can cause regional lymphodemas, which is swelling of lymph nodes, like in the specific area where they are, where the impetigo has, where you're having where the lesions have ruptured. So now we're going to go to the bullous impetigo, the pathogenesis of it. And once again, we talked about the bacteria that it's caused by. This is the Streptococcus aureus. Now this one is a little bit different because it does the same toxin that has exfoliative toxins it's releasing, but it's A and B. And so each one of those A and B it's a little bit of a different, because it depend on how, let's say severe, but it'll depend on how much further the infection goes, I guess I want to say. It starts as small vesicles progressing into superficial bullae. When I say that, so the difference if you look at the two. So with your non-bullous, it's going to have it's going to be a blister, but it's got this really specific color to it, and it's inside of a blister you can't really see what's inside of it, but it still is a totally different color. With the bullae, and these are going to be large. So with the non-bullous, the blisters are smaller. With the bullaeous impetigo, their bullae are much larger, and there's like a clear to dark color almost inside of it. And once they rupture, it creates a dry red scaly rim. And it's called, I would try to pronounce that name, but it's erythematosus. I killed that one, sorry. But, and it's basically that's describing what, how it looks as far as, the scaly rim and how it's kind of inflamed a little bit, but it doesn't, like I said, it's a lot larger than the non-bullous too. It is, obviously it doesn't form a honey-colored crust. The fluid is permanent and dark-colored when rupture occurs. Infection usually lasts 2 to 3 weeks. Same kind of, thing. Doesn't cause any regional inflaming of the lymph nodes or anything, but it can cause some systemic issues, such as fever, headache, and we talked about that a while ago. It's just your body's response. But the difference is it's usually found on the trunk, axilla, and extremities. And so since 90% of this is found on babies, diaper area is where it's pretty much, that's where you're going to find it in the babies. Normally it's diaper area, especially when they're younger, and then you may have some, come around to the rear end and things like that. So the third one that we really don't talk about because it's really not a type, but it is a type. So when you have non-bullous impetigo, remember I told you it could be either Staphylococcus or it could be Streptococcus. So if it is Streptococcus, which is your group A Streptococcus, which is gas, if it is that type, it can possibly cause a little more issues. And that would be when you come into the eczema. And, its exfoliative toxins create an ulcerative lesion that penetrates the dermis. So like when I tell you an ulcer, so we know an ulcer, and it goes down and it, creates like a cavity or whatever, wherever it's at, it's going to actually come from your epidermis, all those layers, and it's going to all the way into the dermis. And this is where it's going to, we call it a punched out lesion. It's formed with undermined edge. So these you have to look at, you could have a lot of issues with this. These could possibly, destroy healthy tissue that you're going to have a lot of scarring from, if not cause some other problems, So you sit right here on this, on figure 4, it shows like you have your superficial. So that's just, impetigo from the group A strep that, which is going to just pretty much occur on the outside or things that may cause it. So, if someone has pharyngitis, actually, they see a lot of people that have the pharyngitis, the same exact bacteria that is pharyngitis also is impetigo. Then we have scarlet fever. And so get a little bit, into it as far as we can look at having some possible heart issues come on with this, some rheumatic fever with it. I'm sorry, rheumatic, I'm getting there. And then invasive. So invasive is where we don't want to go with this. This is why, like I said, proper treatment early is like key on with this. Cellulitis, necrotizing fasciitis, and toxic syndrome. And they also, you have the scalded skin syndrome too, condition syndrome, that is like, it's just the skin just peels off, and it's, that is more superficial. But with superficial conditions, what's going to occur is eventually, if it's not cleaned properly, and when I say this, things are mostly in children, so obviously their hygiene's not the greatest because that's our responsibility to do, that you're looking at infections from outside sources coming in that's not this. So, you have other infections you'll be fighting, and then you got a whole other issue going on there. So eventually you have the deficiency of the antibody that destroys pathogens by phagocytosis, which we know that's just engulfing and eating, and it's our body's immune response to take out and eradicate these bad bacteria that come in our body. It's not able to do that. So it has a deficiency of the antibody, and so that to destroy it. So that's for your causation of its pathogenesis as far as, transforming from the non-bullous into the eczema. Sorry, we'll go to the next one. So we'll go over some complications here. So in the complications, you'll see I've listed three. I mean, obviously there's a whole bunch more as far as a lot of, things you could look at, but these are pretty spot on. So your first one's going to be post-streptococcal glomerulonephritis. Okay, just look at the glomerulonephritis. So basically you're going to know it has to do something to do with the kidneys and an infection or inflammation in the kidney. So, it's like with so many other things. When anything becomes systemic in our body, the first thing that our body says, well, we don't need that anymore, is your kidneys. And so it can be one when it's left untreated and with different bacteria, this body's immune response to the impetigo is that it accidentally attacks the kidneys, causing inflammation in the glomerulus. And for most people, they recover from that, but not everyone can. It can cause long-term effects, especially if you have a patient has kidney dialysis. They already don't have function like they should anyhow. So this could be really detrimental and it could shorten the life of someone. I'm gonna leave the middle one to last. The last one is rheumatic fever, inflammation condition caused by overreacting to the bacteria from impetigo. Healthy tissue is attacked, and symptoms appear as fever, painful joints, or even occasionally causing some heart damage. So once again, like I said, some of this stuff can really be some long-term effects that people could deal with, and we think as, oh, it's just simple rash that school-age kids get. The middle one, so you'll see a child there that has it in their eye. It's called cellulitis, potentially life-threatening infection that affects the tissue underlining the skin and eventually may spread to the lymph nodes and bloodstream. I'm going to tell you a little bit about this. So I have case complications on the side. The picture here, it's an example. This child has periocular cellulitis. And it took a lot of research to try to get to what I can put on this, but first the child contracted conjunctivitis, which we all know is pink eye. What do kids do with pink eye? They rub it, whatever else. Eventually, they get rid of it. But this child also had a respiratory infection at the same time. So you're looking at a child that's immune system didn't like it was doing so well. So child's in first grade or kindergarten. I think it was kindergarten. Or, yeah, kindergarten or first grade, whatever. And they go to school and they come home and, next thing you know, because there's a low immune system, they got something on their nose and, basically told, oh, it's just impetigo, it's okay, no problem. Well, the next thing you know, this child is starting, their eyes hurt. And I'm thinking, oh, great, the pink eye must be coming back, right? It must be just pink eye. It must not be, gotten. This is why it's important to, especially when you have school-age children, to understand or at least identify what school-age diseases look like, because this is where they could go. This is a child who was really and truly perfectly healthy in the eyes of their parents. This child had drowned 2 years before that, had accidental drowning as they call it, but had collapsed lung and all that, but had recovered fully from it. And to the family's eyes, no idea that this child even had any other issues. So anyhow, so the child, this is day 7. You're looking at day 7. Child could not open the eye at all. The eyelid was completely swollen shut. It was crusted. And like I said, reminded you so much of like looking at pink eye. You're looking at, some of the little infection. But, so, due to a family friend who's an ER doctor said, this child needs to go to the hospital. I'd bring him, get him seen right now. So that's what happened. Child was brought to the ER. The child was diagnosed with periocular cellulitis, which most people have never heard of probably, which periocular cellulitis can become intraocular cellulitis. And so what happens with that, then the infection gets behind the orbit of the eye into the septum, the orbital septum, which is your direct contact. The blood flow and everything goes straight to the brain. So if the infection gets there, then once it gets to the brain, what can you do? So, this child was observed 24 hours. If it spiked any type of fever, anything else, the child was going to be rushed to a pediatric hospital that had a trauma ophthalmologist, basically. That never occurred. Child was given antibiotics, strong antibiotic regimen, and, did recover. But this right here is, what I talk about as far as, like, you just don't know how that, how someone that could be 7, 8 years old, you have no idea, because come to find out, a year later, this child was diagnosed with, she had basically an immune deficiency. She had no immunity that built up for the common cold and had to be revaccinated and everything else, and still does that today. But no idea until, went through all this. And then we'll come to, impetigo. It is a skin infection. Talked about, it's what the bacteria is caused by. Sometimes it's both. You can have both at one time. Patient outcomes vary due to many factors. It's going to due to how fast you get the treatment, what age. I mean, if the child's younger, it's hard to say like, hey, don't touch your hands. I mean, don't touch your face with your hands and touch somebody else. That's the first thing kids do. They like to touch everything. But it's also important as parents to be able to, like I said, have the understanding of how they get the disease, what could happen, and things to look out for. And most impetigo is treated with topical antibiotics, but when the different types of bacteria have to be obviously treated with, sometimes with an oral antibiotic, sometimes they'll be taking a topical and an oral antibiotic. And then there are those cases where you may have a MRSA, you may have a antibiotic resistant bacteria that has slid in there somehow or another, and they would have to be hospitalized because the only antibiotic you can normally go get for that is some vancomycin, and you can't take that, or other medications, other antibiotics that cannot be taken orally, they have to be given intravenously. So a person is considered contagious until the rash is gone, or if they get on antibiotic, then by day 2, they may still have the rash, but at day 2, they've had antibiotics system for 48 hours, then they're not considered contagious anymore. Like we were talking earlier, it has long-lasting effects as far as it could just be as little as scarring or all the way to organ failure, because if the kidney shut down and stopped working, then, you've got organ failure at this point. So, the disease must be treated like any other disease. It's a disease. We have to educate ourselves, be knowledgeable, and get to treatment as fast as we can. It is, although it's been termed the name school sores, to some people, with those with low immune systems, as the case we were talking about just a second ago, or diabetes or AIDS, or, someone has cancer or whatever it is, contracting impetigo could be a matter of life or death for some. And, with that, I just want to thank you. My name is Melissa Rona, and, this is my presentation on impetigo. Thank you.